How is the situation in your state, Dr. Lee, about the COVID?
Terrible.
Terrible, right?
We're in the middle of a big surge at the hospital and in
Oh,
the city.
oh yeah.
We have 729 just in the hospital, our hospital, Methodist Hospital.
Wow.
269 deaths already.
Yeah. Wow. It's a lot.
It's like New York.
Yeah. And also Florida. Oh, Florida
Yeah.
has a lot of people.
Bad.
Yes, it's impressive. Also, when I was talking yesterday with the people from Guatemala, this is a it's very small country, and they has a lot of people with COVID. They,
Yeah.
they have incredible how much they have.
Oh, it's
And,
terrible.
in Venezuela, many people, especially in the Zulia, in Maracaibo, it's in the border to Colombia, many people die, especially many doctors. They have a big list.
Yeah.
Yes, it's terrible.
Bad.
Very bad. En Maracaibo han muerto bastantes, ¿no, doctor Musi? Ujú. No le escucho que tiene el micrófono apagado.
14, 14.
But I read more. Somebody sent me a big list of people that is dying. A special doctor, they has also one ophthalmology, young ophthalmology that died in the terrible situation. In all the countries. Most of the country. Let me say 10, 5. Yeah. It's difficult to count. Also, in Europe, like Italy, I have a cousin in it, and she told me that they are preparing them for October, for the second time.
Yeah.
They're preparing, a lot of people for this.
Same here.
Yeah, I imagine. It's difficult.
How many people normally come to this?
Well, it's variable. Sometimes, in general, sometimes we have 100, more than 100.
Wow.
I have connection in YouTube and in Facebook. But the problem now is the connection in most part of South America, the internet sometimes is unstable, and sometimes you can see the people try to connect. And for somebody, it's easy to do for YouTube because it's more stable, the connection, no? Sometimes it's unstable, it depends on the internet of each country. Sometimes I think Venezuela is sometimes very unstable. Sometimes I think in some parts of Colombia, somebody told me about this, one of the doctors told me. For this reason, many people try to do by YouTube it's more stable for them, more easy also.
How long do you normally go to?
The talk?
Yeah.
Whatever you need.
You want them to ask question or?
You can do whatever.
Okay. I'll just do the talk and let them ask me at the end.
We have ophthalmology resident. We have neurology. We have neurosurgery. We have the neuro-ophthalmology, of course.
Yeah.
And also we have some are internal medicine. They are doing medical internal medicine.
That's fantastic.
Yeah, especially the more impressive is the neurosurgery. Because it's very funny. They are learning neuro-ophthalmology too.
Yeah, that's good. How many countries do you have?
Well, we have different, more from South America, Central America. We have also Mexico, Guatemala, Colombia, Venezuela, Ecuador, Peru, Bolivia, Chile, Argentina, more of the countries. I think we have people, Bolivia, we have for all the countries, Santo Domingo.
That's fantastic.
Different countries. I don't want to forget any country because people is going to be Brazil. They're going to become angry with me. I forget. Yeah, no, yeah. Sometimes it's difficult to try to fit the hour for other people because you
Yeah.
know sometimes it's later, sometimes it's late, and I try to do in the best way that I can. All people can come here. And
That's
also
nice.
some people from United States sometimes connect to make connection. Special because many Latin American people are living in North America, in
Yes.
North American, and also some are in Europe, especially in Spain. Well, it depends of the hour for them. Uh-huh. Let me check something here. We are doing a good connection, yeah. And you have now, we have connecting people now in YouTube already. And let me check. Hmm. But you usually do has a lot of at that time, right? By Zoom or by any connection of this?
Yeah,
Um, Especially at that time, right?
for sure.
Uh, the COVID is becoming more crazy. Also, I began last year, but last year when I began, I tried to do, one time a month. I didn't have too much experience with this. Also, I don't have too much, but I try to do the best. But now with the COVID, we are doing a little more frequently.
That's
Sometimes
fantastic.
we combine a little cultural thing, in
Hmm.
order to change a little bit. And also for the resident, I think it's good for them too.
Yeah.
Mhm. Okay. In 5 minutes, we are going to begin. Uh, Let me. uh mhm. Ready to record. Okay. Mhm. They are connecting. Yes. Okay. Okay. Stop a little bit here. Stop. Let me see. Let me. Okay. We had some people in Facebook. We had some people in YouTube. We have from now 11 fixing people outside connecting now. Let me see. Okay. Let me share here. Okay. Okay, I will introduce you first.
Okay.
And we can. I will do in Spanish. After this, we continue in English. Buenas tardes. Quiero agradecer al doctor Andrew Lee, por acompañarnos esta tarde. Él nos va a hablar sobre los 5 síntomas que usted nunca debe ignorar. Antes que todo, voy a presentar al doctor Andrew Lee. El doctor Andrew Lee es profesor de oftalmología de Weill Cornell Medicine. Es jefe del departamento de oftalmología del Hospital Metodista de Houston, en Texas. El doctor es profesor adjunto de oftalmología en Baylor College of Medicine, en el Hospital y Clínica de la Universidad de Iowa y en la Universidad de Buffalo. El doctor es profesor adjunto de oftalmología y profesor clínico de oftalmología, tanto del Departamento de Oftalmología y Clínicas de Ciencias Visuales, en la Universidad de Texas de Medicina, en el MD Anderson Center en Texas y AM College of Medicine. El doctor es presidente del Blanton Eye Institute, también en el Hospital Metodista de Houston, y es profesor de oftalmología, neurología y neurocirugía en los hospitales que ustedes pueden ver, casi todos en Texas. El doctor ha formado parte del board editorial de 20 journals oftalmológicos, entre ellos el JAMA, Survey Ophthalmology, The American, The Canadian and the Japanese Journal of Ophthalmology, y también del Journal de Neuro-Ophthalmology y The Eye. El doctor tiene más de 500 publicaciones en journal y 8 libros publicados. Y asimismo ha sido expositor en 300 conferencias tanto nacionales e internacionales, y 14 de ellas llevan su nombre. Asimismo, el doctor ha recibido honores en la por la Academia de Oftalmología, los más grandes honores, como los pueden ver, y también fue expresidente de la Sociedad Norteamericana de Neurooftalmología, del NANOS, para la mayoría de los neurooftalmólogos que lo conocen. Su mayor interés en la educación de los residentes. Ha recibido el premio de enseñanza para residente y 8 veces en 5 instituciones académicas diferentes. Thank you, doctor, for being with us to teach us. Thank you so much. I will stop share, and you can share with.
Okay. Is it showing up?
Yes, you can put.
Okay, great. Well, thank you for having me, Emily, and thank you to the Latin American Eye Group for having me to be your speaker tonight. I want to talk to you about 5 symptoms that you should never ignore in neuro-ophthalmology. I don't have any financial interest in the context of this talk. And these are the 5 symptoms that I hope that you will never ignore. The first is acute painful loss of vision in an elderly person. The second is acute painful ophthalmoplegia in an immunocompromised person, but especially a diabetic in diabetic ketoacidosis. An acute painful bitemporal hemianopsia, which is pituitary apoplexy until proven otherwise. Acute painful anisocoria with a big pupil, which is the rule of the pupil. A pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise. And acute painful anisocoria with a little pupil, that's the Horner syndrome, and that's a carotid dissection or a vertebral dissection until proven otherwise. So you'll notice that all 5 symptoms have the same stem, acute and painful, followed by a neuro-ophthalmic sign. So the combination of acute and painful as the symptom and any neuro-ophthalmic finding on this list, you really should never ignore these conditions because they're life-threatening. And so really, it falls upon you as the physician, and you need to help your residents and your fellows and your technicians to be trained to recognize these 5 conditions. So one of the behavior changes that I'd like to ask of you is when we get off the call and tomorrow in your clinic, if you just go through your staff and your residents and say, look, these are the 5 things where I'm going to be the leader, but if they fall down the hole, it's really on me. So we really have to make sure that all the ducklings are in a row and make sure that we are triaging these patients appropriately. So the first condition that we're going to talk about is the acute painful vision loss in an elderly patient. And this is something that everyone knows well, but I want to emphasize some key points about giant cell that that sometimes are under-recognized. Obviously, if it's an elderly female patient with acute onset headache, jaw pain, temporal pain, near ear pain, and loss of vision, usually from ischemic optic neuropathy, and they have elevated acute phase reactants, the sedimentation rate, and the C-reactive protein, everyone knows that that's giant cell. And so the patient that comes in like this with the complaint of the artery is hurting me on the side of my head, nobody is going to miss that. Even orthopedic surgery knows that that is temporal arteritis. It says right there, I have GCA. But you need to recognize that any pain in the distribution of the external carotid artery can be a sign of giant cell. And it's particularly dangerous when the eye exam is normal. So because giant cell arteritis is a medium to large vessel vasculitis, any patient who complains about face pain, nose pain, eye pain, ear pain, jaw pain, tongue pain, or neck pain even could still be giant cell arteritis. And you need to work it up as that, even if the eye exam is normal, and that means doing the sedimentation rate and the C-reactive protein on these patients. If you look at this series from Kelly, the top 4 symptoms here in these 100 patients with biopsy-proven giant cell, the top 4 symptoms are headache, and there's no specific thing about the headache that tells you it's giant cell. So as opposed to migraine and tension headache and trigeminal neuropathy, which have clear diagnostic criteria in the International Headache Society criteria for headache, giant cell arteritis has no criteria. It can be mild, moderate, or severe. It can be temporal. It can be diffuse. It can be facial pain. So the headache is nondescript, and you cannot use the characteristics of the headache to decide whether this person has giant cell or not. The second is polymyalgia rheumatica. Polymyalgia rheumatica is pain in the shoulder and hip girdle. That's proximal hip and shoulder girdle. It's usually bilateral and symmetric, and it's worse in the mornings. They're stiff in the morning. That is PMR, polymyalgia rheumatica. And so one of the questions that you need to ask elderly patients is not, do you have joint pain? Because they always say yes. All old people have joint pain, including me. The way you have to ask it is hair, chair, stare. Does it hurt if you raise your arm or comb your hair? Is it difficult to climb up the stair, or is it hard to get out of the chair? So that is proximal shoulder and hip girdle pain and AM stiffness. Number 3 on the list of presenting symptoms is fever of unknown origin. That one is very, very difficult to recognize as giant cell if you're not looking out for it. And then the number 4, the one that I really want to emphasize to this audience, is transient vision loss or transient diplopia. That's patients who have visual symptoms without losing their vision. So patients who have visual symptoms without loss of vision, that's a transient vision loss, amaurosis fugax. That is the number 4 presenting symptom, at least in this series. And in addition, if you look down here, the jaw claudication, the temporal artery tenderness, the ones that are all in the book, these are very uncommon to be the presenting symptom. The presenting symptoms are headache, polymyalgia rheumatica, fever of unknown origin, and amaurosis fugax or transient diplopia. And so if you look at this series from the British Journal of Rheumatology, these are biopsy-proven giant cell arteritis cases. We have 146 biopsy-proven cases here, 23 patients, 16% of this cohort lost their vision, and they had symptoms on average 1.3 months prior to going blind. So we had a chance to make the diagnosis in these people, and we didn't recognize it. Fascinatingly, 35% of the cohort has polymyalgia rheumatica. So 1/3 of the people in this study had PMR, hair, chair, stare, and they had those symptoms on average 10.8 months prior to losing their vision. And then the third symptom, 65% of the people who went blind in this study had premonitory symptoms, amaurosis fugax, transient vision loss, or transient diplopia, on average 8.5 days prior to going blind. So in this study, there was a clear delay in the diagnosis in 65% of the patients. 15 of these 23 people really didn't have to go blind. And so some things you don't know about things you know well. You, of course, know giant cell very well. But the thing I want to emphasize is the most common presentation, anterior ischemic optic neuropathy, is not the only way this comes to us. The other ways that you need to know that are less common are posterior ischemic optic neuropathy. It's posterior because the disc is not swollen. Anterior, the disc is swollen. Posterior, it's a retrobulbar optic neuropathy. And the most important symptom, transient monocular or binocular vision loss, amaurosis fugax, or transient diplopia in the elderly. These distinctive premonitory symptoms precede the vision loss and are your clue that it's giant cell arteritis. And so one of the important take-home messages about giant cell is when you look in the fundus in someone who's elderly, who's lost their vision, it's actually better if their disc is swollen, because if it's swollen, at least it could still be non-arteritic anterior ischemic optic neuropathy. But if the disc is normal appearing, that is PION, posterior ischemic optic neuropathy. That's a retrobulbar optic neuropathy, and that's almost always going to be giant cell in the elderly patient. The other thing you should be looking out for is pallid disc edema. The disc is both pale and swollen, and you can see the three representative examples here in these photographs where the disc is pale and swollen at the same time. So if you see this pallid edema, you really should think about giant cell. One of the things that you should be thinking about doing is a fluorescein angiogram. Here you can see in the fluorescein, the dye is just not appearing in this medial choroidal artery distribution. So patients who have either no disc edema, retrobulbar optic neuropathy, PION, posterior ischemic optic neuropathy, or patients who have pallid edema, a fluorescein angiogram can show choroidal perfusion deficit. And when we have choroidal perfusion deficit and optic nerve ischemia, those two circulations suggest that it's vasculitis. And the most common vasculitis that we see in the elderly is, of course, giant cell. So here's a patient that was referred to me who was an 80-year-old female with right-sided vision loss to hand motions vision, had a relative afferent pupillary defect, and the fundus was normal. And they did an MRI scan because it was a retrobulbar optic neuropathy and it was normal. And the reason it was normal is there's no MRI finding of giant cell arteritis. So you can do a giant cell arteritis workup, including an MRI. And if you do the MRI and you see enhancement of the nerve or the sheath, that's suggestive of giant cell. But if it's normal, it really doesn't help. And this is the fluorescein angiogram of that same patient showing the massive choroidal perfusion deficit. You can see that the medial and lateral choroidal artery distribution here is markedly different, with non-perfusion all the way out in the choroid here. And so optic neuritis and all the other retrobulbar optic neuropathies cannot cause this level of choroidal ischemia. So one of the main pearls that I'd like to leave you with for giant cell is when you have a patient who is elderly, beware of the diagnosis of retrobulbar optic neuritis. Now, optic neuritis can occur in elderly patients, but you really should be thinking about giant cell arteritis and posterior ischemic optic neuropathy in patients who have retrobulbar optic neuropathy acutely in the elderly. So the wicked good pearl is retrobulbar optic neuritis in the elderly person. You should be thinking about PION, posterior ischemic optic neuropathy, and that's almost always the arteritic form, which is giant cell. And the second pearl, pallid edema, sometimes looks like no edema. It's this pale and swollen disc. There's no hemorrhages. It doesn't look that bad, but the dead nerve can't swell. So the big red flags for giant cell arteritis are severe vision loss. That's when the patient is light perception or no light perception vision. If it's bilateral and simultaneous vision loss. If we have transient vision loss, that's amaurosis fugax, that is essentially not seen in the non-arteritic form of AION. So if someone comes to you and it looks like non-arteritic AION and AION, but they said a week ago I lost my vision, or a week ago I had transient double vision, those two premonitory symptoms suggest that this person has giant cell, because NAION is not a thromboembolic disease. That's why we don't do carotid Dopplers and echoes on NAION. It's not really a transient phenomenon. And so if you have transient visual symptoms, that's a big red flag that it's giant cell arteritis. And of course, polymyalgia rheumatica, hair, chair, stare, that's a third or more of the patients with giant cell who are going to lose their vision have this. So there are 5 things to remember about acute vision loss in elderly patients. One's giant cell arteritis, and of course, the other 4 things are also giant cell arteritis. This is another patient who was sent to me with this very unusual field defect of central scotoma with breakout to the periphery in the right eye. The left eye was normal. They were sent to me with these multifocal cotton wool patches, and the disc was normal. It was sent to me as hypertension because the patient's blood pressure was markedly elevated, but hypertension is not likely to be the cause of the retrobulbar optic neuropathy and the cotton wool patches here, because the blood pressure in this fellow eye is the same as the blood pressure in this right eye. And so really we should have bilateral symptoms here. That's already a big red flag that this is vasculitis. And so a fluorescein angiogram was performed, and even though the disc is normal, you can see the marked non-perfusion of this disc. This choroidal perfusion delay is very characteristic of giant cell arteritis. And so when we see the dye not filling the choroid, even at this late frame, that's a big red flag that it's giant cell. And of course, the biopsy was performed, which showed this multinucleated giant cell on transluminal infiltrate consistent with giant cell arteritis. The other thing that you need to be aware of in giant cell arteritis is the biopsy reports are sometimes very misleading. So this is a biopsy report that says impression, no giant cells seen, no active arteritis. You should know, however, that there's a different form of arteritis, which is called healed or steroid-treated arteritis. The healed or treated arteritis does not have giant cells or the transluminal infiltrate. So you need to read the body of these pathology reports, and it could show focal disruption of the internal elastic lamina, areas of fibrosis, or even just a few lymphocytes in the adventitia. All of these are red flags that we might be dealing with healed or treated arteritis. In addition, they might not see arteritis because nothing was in there, either a vein or a piece of connective tissue or a nerve was biopsied. So you really got to read the body of the report to make sure that we got a good specimen and that we don't have healed or treated arteritis. So you should be aware of the very unusual presentations in addition to the normal presentations of GCA. GCA normally comes as AION, especially pallid edema, but you've seen multifocal cotton wool patches now, the retrobulbar optic neuropathy, posterior ischemic optic neuropathy, in which case the nerve is normal, non-embolic central retinal artery occlusion, that's 10% of the giant cell arteritis cases present like that. And the most important pearl for you is transient vision loss, amaurosis fugax, or transient diplopia does not occur in the non-arteritic form of AION, and therefore you should be thinking giant cell. And doing a fluorescein angiogram to look for simultaneous choroidal perfusion delay or simultaneous optic nerve and retinal artery level ischemia is also suggestive of giant cell, because that's two circulations, and when you have two circulations, you're more likely to have vasculitis, and that vasculitis in the elderly, of course, is giant cell. I want to switch gears and talk to you about this patient who had a holiday headache. She's 22 years old. She had the worst headache of her life. The tech writes 2050 ? Effort. She has blurred vision as her complaint, and the fundus exam was normal. The Humphrey is completely black, and it was written by the tech as unreliable. And it's unreliable because the patient has the worst headache of their life, and so they're not really going to want to be pressing the button or taking a test. Of course, it always happens at Friday, 4:45 p.m. So the pearl here is, please don't write unreliable field and just leave that on the chart. You have to at least do a confrontation visual field on these people to determine whether or not they have a bitemporal hemianopsia. You're not trying to detect some arcuate scotoma from glaucoma. You're really just trying to determine, is it a bitemporal, yes or no? And the confrontation field can do this. The life-threatening diagnosis in a bitemporal hemianopsia, of course, is pituitary apoplexy. If you look at the incidence of pituitary tumor, it's maybe as high as 7 per 100,000 in the general population, and maybe as high as 1 in 500 individuals in elderly patients over 65 years. My friend Barrett Katz would say the average ophthalmologist should see 1 pituitary tumor a year, and he would ask you, are you missing your quota? Pituitary apoplexy is a pituitary adenoma that presents acutely. It's usually associated with severe headache, often the worst headache of their life. It presents with the bitemporal hemianopsia, but any type of afferent presentation can occur, loss of vision in one eye, both eyes, or even homonymous hemianopsia if it's compressing the optic tract. Apoplexy is deadly and kills 8% of the people, and you really have to have cortisol. You kind of need your pituitary gland. It's the master gland, and of the pituitary hormones that could be low, cortisol is the one that kills you. You need an emergent scan, because what we're looking for is this. This is a intracellular mass with supracellular extension. You can see the rim of hyperintense signal intensity surrounding the hypointense necrotic core. This is the characteristic feature of pituitary apoplexy. This bar at the top is the poor chiasm being worn as a hat. If you look at this series from Semple et al. In neurosurgery in 2005, there are 62 patients, average age 51. The average time to presentation was 14 days after the ictus, which was, they had the worst headache of their life. They went and lie down and try to sleep it off. And then 14 days later, they show up in the eye clinic with this bitemporal hemianopsia. 81% of the cohort had no prior history of pituitary adenoma. They don't know they have a tumor. Of course, they're going to have a bad headache, decreased acuity in 56%, and 34% of the people present with the bitemporal hemianopsia. So an acute and painful bitemporal hemianopsia is pituitary apoplexy until proven otherwise. In this series from Semple, 73% of the cohort was panhypopit, and 8% had diabetes insipidus. So if you have DI, you might DIE. So diabetes insipidus kills people. And apoplexy is a clinical diagnosis. So it really doesn't matter what the radiologist says about hemorrhage or no hemorrhage. It's a clinical thing. So acute, painful, bitemporal hemianopsia with a pituitary lesion, you really should be thinking about apoplexy. And again, the unreliable visual field, the wicked good pearl is you need to do a confrontation field, even if the patient's Humphrey or automated perimetry is unreliable, because if you don't, what you're really doing is you're saying, I have no visual field. It could be a brain tumor, even apoplexy, and I'm not doing anything about it. So you really cannot leave unreliable as your visual field documentation. This patient is a 35-year-old white male with diabetes, with acute ophthalmoplegia. And normally acute ophthalmoplegia in a diabetic patient means a diabetic palsy. So you can have a diabetic third or a diabetic fourth or a diabetic sixth, but a diabetic patient is allowed only one cranial neuropathy at a time. It's a mononeuropathy. So you're only allowed to have a third, a fourth, or a sixth. You can't have a 3 and a 4, a 3 and a 6, a 4 and a 6. You can't even have a 5 and a 4 or a 3 and a 5. Any combination beyond a mononeuropathy is very dangerous. So in this particular example, they have diabetic ketoacidosis. That's the risk factor for infection. They have a complete ptosis on the left, consistent with third nerve palsy. And the thing that's dangerous is they have an almost complete ophthalmoplegia. So when we have a third nerve palsy, the eye is going to be down and out. They're going to be exotropic. And what we're going to be looking for in the exotropic eye is intorsion and downgaze. So if they have intorsion and downgaze, that means that the fourth is still intact. If they don't have intorsion, then you have a 3 and a 4, and that means you don't have a diabetic mononeuropathy. It's not ischemic, it's a mass lesion. Same with the abduction. So we want to make sure the 6th is intact, and we want to check cranial nerve 5, V1, V2, and V3. So the dangerous part of this stem is the almost complete left-sided ophthalmoplegia. And the life-threatening diagnosis in a diabetic, but especially diabetic ketoacidosis, is fungus. The imaging study is going to show a distinctive finding, which is, yes, the cavernous sinus or orbital apex adjacent to the cavernous sinus lesion is going to have enhancement, but this sphenoid is opacified as well. So adjacent sinus enhancement next to the finding that you're seeing clinically is a very, very bad sign for fungus. And the book answer is DKA, diabetic ketoacidosis. But you should not procrastinate on seeing any of these patients who have acute painful ophthalmoplegia in the ICU, or if they have had surgery, or they're a cancer patient on chemo, or they have been on long-term immunosuppressive agents or steroids, if they have chronic renal dialysis, chronic antibiotic treatment, or they're the survivor of a solid organ or bone marrow transplant. These patients are all immunocompromised, and that is the unifying mechanism that suggests this might be fungal disease. So now you've seen two dangerous things. One is the selloturcica, that's pituitary apoplexy. I told you it can go straight upstairs and get the bitemporal hemianopsia, but if it goes laterally, it'll go right into the cavernous sinus and produce ophthalmoplegia. And here, the sphenoid sinus is opacified, and if that goes laterally, that'll go into the cavernous sinus, and the internal carotid artery is right here. And so we definitely don't want to miss a cavernous sinus syndrome related ophthalmoplegia from either pituitary apoplexy or sphenoid sinus infectious disease like fungals. So here's one of my cases from when I was at Iowa. It's a 76-year-old woman with acute myelogenous leukemia, AML. She's on day 13 of induction chemotherapy. The resident was called to the floor to see the patient because they had a 2-day history of worsening right-sided periorbital swelling and erythema. So you can see the mild erythema that is present in this patient, the chemosis and the injection. Patient really didn't have any pain, was afebrile, had no white count because they were suppressed. CAT scan was performed, which showed pansinusitis, non-specific fat stranding in the orbit, and you can see the maxillary sinus has mucosal disease as well as in the nose. The resident asked me, is this orbital inflammatory pseudotumor or Tolosa Hunt syndrome based on the painful ophthalmoplegias and also the chemosis and injection? And the wicked good pearl here is don't give the diagnosis of immunocompromised patients, immunosuppressed patients, anything autoimmune. So they don't really have an immune system. And so really they shouldn't be getting idiopathic anything, including the Tolosa Hunt syndrome, idiopathic granulomatous cavernous sinus syndrome, or orbital inflammatory pseudotumor. Those are just not going to be likely. You should be thinking about infection in immunosuppressed people. ENT did an endoscopy and went up that patient's nose. They found this pale necrotic tissue. They biopsied it. It came back angioinvasive mucor. So here you can see the fungal elements. All of this pansinusitis that was seen on the CAT scan was fungus, and it was right into the blood vessels. That is angioinvasion. That is very dangerous. In the book, it says to look out for this black eschar thing. This black eschar represents necrosis. You can see it's already on the other side because the starting point was midline. It went to the right and then the left. Please don't wait for this black eschar thing. That is an end stage finding. The black eschar means this guy's heading to orbital exoneration. And mucor and aspergillosis have a similar presentation, but aspergillosis can present in immunonormal people, and mucor is usually the immunosuppressed people. You need to be aware that the MRI scan might be normal in fungal apex disease because you need the contrast material to see the enhancement, and many of these patients are sick and their kidneys are not functioning well and their glomerular filtration rate is not good, and so they might not give you the contrast. And fungi are dark on MR. T2 going to be very dark, so it's going to look like air in the sinus, and you need to have fat suppression to see the enhancement. Super dangerous to see these cases because you might be tempted to give the person steroids on the assumption that it's inflammatory optic neuritis or orbital inflammatory pseudotumor or Tolosa Hunt. And if you give steroids to fungus, you'll get fungus among us. This patient is a 60-year-old diabetic. He has new onset ptosis, adduction, elevation, and depression deficit, 45% diopter exotropia, the eyes turned out. It's thought to be an ischemic third, and they say come back in 6 weeks. So what's wrong with this picture? What's wrong is we didn't check the pupil. So here's the pearl for this case. You need to tell your technicians and your residents and your fellows, if the patient's complaint is diplopia or ptosis, and you have to, or if you have to lift up a ptotic lid, don't dilate that person. So you have my permission not to dilate third nerve palsy. You can look at their fundus after the workup is performed because we really need that pupil. And what we're looking for is pupil involvement. And that is the rule of the pupil. A pupil-involved third nerve palsy is an aneurysm of the posterior communicating artery until proven otherwise. The life-threatening diagnosis here is aneurysm. And so you probably learned this rule of the pupil. In America, we don't use this anymore. If they have a third nerve palsy, we're going to look for aneurysm, whether it's partial pupil or partial palsy or pupil involved. And that's because it's such a high stakes decision. So the only person you really can watch is isolated, complete palsy with pupil sparing. All these partial palsies and partial pupils and pupil reacts a little bit, all those still need to be worked up as an aneurysm. So even though the rule of the pupil is pupil-involved third nerve palsy is posterior communicating artery and aneurysm, any third nerve palsy except for the complete and completely pupil-spared palsy can still be aneurysm. And so here's the CTA showing the posterior communicating artery aneurysm here. MRA in another patient showing this jalapeno pepper pressing on the third nerve from the PCOM aneurysm. If we identify this aneurysm, and coil or clip this aneurysm, they go home on hospital day 3. If it ruptures, half the people die at the scene. Of the people that make it to the hospital, half of those people are going to be permanently neurologically impaired. So diagnosing this aneurysm before the rupture is critically important, and that person is coming to ophthalmology. So here's the coil that's been placed into this PCOM aneurysm, and it's secure. This is the highest stakes encounter that an ophthalmologist will see. Third nerve palsy could be vasculopathic diabetic third, live, or it could be an aneurysm that's going to rupture in the next 28 days and kill this person. So really, I think you should never ignore third nerve palsy. You should always work that up. So here's my workup, and you need an A, an angiogram of some type to find an A. The A we're looking for is aneurysm. In our hospital, CT non-contrast to look for subarachnoid hemorrhage, followed by a contrasted CTA to look for aneurysm. In every pupil-involved third nerve palsy, but really every third nerve palsy. MRI, MRA is necessary, even if the CT, CTA is negative, because there are non-aneurysmal causes of third nerve palsy. And so we need to do the MRI second if the CTA is negative. And if you still think it's an aneurysm, or radiology is hedging on the reading, or they skull base artifact, or 10 million reasons why they might not want to read it as completely negative, you might still have to have catheter angiogram if your MRI, MRA, or CTA is not of sufficient quality, or if you have insufficient confidence in your radiologist to rule out aneurysm. This patient is a different patient. They have a smaller pupil, but you can barely tell. They were sent for levator dehiscence because they have a high indistinct lid crease here. They have normal levator function, and she was complaining about this ptosis. However, if you look at this patient in the light versus the dark, you can see the anisocoria now is present in the dark. So you can see the tonic eye pupil is slightly smaller. And so you need to look at every patient with anisocoria and ptosis in the light and in the dark. Here's before aproclonidine. You can see the anisocoria. After aproclonidine, there's reversal of the anisocoria, confirming that this is a pharmacologically confirmed Horner syndrome. So in Horner syndrome, the anisocoria is going to be greater in the dark because it's a dilation problem. And if you're using Perlop alone, pupil equal round reactive to light and a combination, that's only testing one of the 3 things you're supposed to be testing. You're supposed to test in the light, in the dark, and swing the light for the relative afferent pupillary defect. About 12% of Horner's patients have either mild or no ptosis, so you got to really be careful about that. And the book Horner's doesn't look like the real world Horner's because people's pupil, as you get older, gets smaller and smaller, so it's much harder to detect it unless you're looking in the dark as well as in the light. And the life-threatening diagnosis for an acute ptosis with a small pupil, the Horner syndrome, is dissection of the carotid or vertebral artery. I love this sign. It says touching wires causes instant death. There's also a $200 fine. And what that means is death is sometimes not enough. The $200 fine is getting a malpractice lawsuit. So in a carotid dissection, we're going to be asking about a history of trauma, but most dissections actually have no precipitating factor. They're spontaneous. They're going to have neck pain, but the neck pain can extend to the face or just be in the eye. You're going to be looking for the distinctive finding, the acute painful anisocoria with a small pupil. That's the Horner syndrome. It's going to be greater in the dark than the light, and you're going to give aproclonidine or topical cocaine to confirm it. But in the emergency room setting, I would just do a CT, CTA of the head all the way down to the neck to look for the carotid dissection. Most dissections are cervical. Both vertebral and carotid dissections, they occur in the neck. They might have amaurosis fugax, or they might have a visible embolus causing a branch or central retinal artery occlusion. And so in the ER, we really don't waste the time with the drops. We just scan them. And this is what you're looking for on the scan. This black circle here is the internal carotid artery flow void, surrounding by this crescent of hyperintense signal. That crescent is the dissected blood in the false lumen. It is hyperintense on T1. In this particular patient, we have no flow up the ipsilateral right carotid artery. So this is an emergency and needs to be admitted to your stroke service. So these are the 5 symptoms that I wanted to cover for you. Acute painful vision loss in the elderly, that's giant cell arteritis until proven otherwise. Please be aware of amaurosis fugax and transient diplopia. The top four symptoms: headache, polymyalgia rheumatica, that's hair, tear, stare, fever of unknown origin, and amaurosis fugax, transient diplopia, or transient vision loss. Acute painful ophthalmoplegia or orbital apex syndrome in an immunocompromised person, but especially diabetics and DKA, that's mucormycosis until proven otherwise. Beware of that because you need a CAT scan. MRI scan might show that the fungus is dark and there's not going to be any contrast, and you could easily miss that lesion. Acute painful bitemporal hemianopsia is pituitary apoplexy until proven otherwise. That needs to be admitted to the hospital because panhypopituitarism occurs in 75% of those patients, and cortisol is the hormone that kills that person. If you see that patient on Friday at 4:45 p.m. and don't give them the cortisol, they'll be dead by Saturday, 4:45. You need to look for the rule of the pupil. That's an acute painful anisocoria in a third nerve palsy. That requires an A. To find an A, that's an angiogram of some kind, CTA, MRA, and digital subtraction angiography, DSA. I start with CT, CTA, but you still have to do an MRI, MRA after the negative CT, CTA because of non-aneurysmal causes of third nerve palsy. If you have an acute painful anisocoria with a little pupil, that's a dissection, usually of the carotid artery. Might have amaurosis fugax or a branch or central artery occlusion. They're going to have neck pain, and you're looking for the crescent sign on the MRI scan. The bottom line is, it's your job. Cataract, 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 third nerve palsy, you still have to scrape that up. I want to end with one of my patients who came to see me recently. She's 73. Her chief complaint when I saw her was none. And that's because I had seen her before in 1997. I had diagnosed her as having paraneoplastic optic neuropathy. She recovered. We did a chest x-ray. We found the small cell carcinoma. It was resected. She was treated with chemo and radiation. That was 1997. And that case was written up in the Journal of Neuro-Ophthalmology. She came back to see me in 2010 when I first came back to Houston. And she said, "You don't remember me, do you, Dr. Lee?" I said, "Well, sure, maybe. I had lung cancer and you found it in my eye." "Really?" "Yeah, you wrote it up in a journal." I said, "Oh yeah, sure. Now I remember. How are you? Why are you coming today?" She said, "The only reason I was coming is to tell you thank you." So this patient waited for me to come back from Iowa to Houston and made an appointment just to say she was still alive. So of course, wrote it up, got 2 papers out of the same patient. She is the longest term survivor of paraneoplastic optic neuropathy in the literature, but also in the entire world. So she is alive because I was alive. I want to end with this case just to take home the vertebral artery dissection case to you. This is 33-year-old white male, transient dizziness, blurry vision, followed by loss of consciousness when he was watching bungee jumping at the Iowa State Fair. So he was watching 2 hours of neck rotation. When he woke up, he had bilateral ptosis and exotropia. He had a non-contrast CT, which was normal. He had an MRI scan, which was read as normal. There was no third nerve lesion. This vertebral artery was read as atretic, but you can tell already that it is dissected because there's no flow right there. Flow, no flow, and then it flows again. We did not discharge the patient. I told him, "Look, this is a dissection." And within just maybe an hour, he developed this locked-in syndrome from progression to the thalamo-mesencephalic junction. You can see the ischemia and the periaqueductal gray here extending to the thalamus. He developed the top of the basilar syndrome. He received intravascular TPA. It was locked in, but he got better, recovered, walked out of our hospital. He wrote a book about it called One Fine Day. I received a phone call from this patient. "Hey, Dr. Lee, you don't remember me probably, but I had a stroke at age 33 and you helped me at Iowa." "Sure, I remember you. I was just calling to let you know I went back to college. I got married. I have a new baby. His name is Andrew." I said, "That's so great. Congratulations." He said, "No, Dr. Lee, you don't understand. His name is Andrew." So to me, these 2 patients exemplify why I decided to go into neuro-ophthalmology. I decided to go into neuro-ophthalmology because I felt I could make a difference. And I think that's why you're Zooming with me right now, is that you believe you make a difference in your part of the world. John F. Kennedy would say, one person can make a difference and everyone should try. And I thank you for your time and attention. I'd be happy to answer any questions you might have.
Thank you so much, doctor. Wonderful talk. let me see if we have any question here. Si quieren hacerle alguna pregunta al doctor, is what's great. Doctor, what do you recommend for the treatment in arteritis, ischemic neuropathy? What is your experience with tocilizumab and this kind of thing?
So steroid is, of course, the mainstay. In patients who have vision loss, either transient or permanent, I give intravenous steroids. There's never been a head-to-head study on IV versus oral, but I prefer IV if they've lost vision. I give oral steroid if they haven't lost vision. Tocilizumab is an interleukin-6 blocker. We use it as a steroid-sparing regimen. It was shown in a randomized controlled clinical trial to be able to get people off steroid quicker. So if you have it available, I think it's a really good option for patients. And the main driver is it's expensive, but it does get people off steroid quicker, but it's super expensive.
Okay. There has too many congratulations here. You say, Asdrubal Moreno say, wonderful talk, thank you. Marcela, she's from Brazil, she say, excellent, Dr. Lee, thank you very much for the opportunity. Macarena say, great presentation, thank you. Ana Barrio, brilliant, she's from Paraguay. Ada from Santo Domingo, great. Monica from Mexico, amazing, thank you so much, Dr. Lee. Aide from Argentina, excellent, agree. One can make a difference and your tip in that help to make it. Tamara from Mexico, congratulations, thank you. Your conference was excellent as usual. Ana Milena say gracias from Colombia. She say gracias. Thank you so much for the talk. Let me turn off this. Let me see. Let me see. Okay. Dice Ana Milena, okay. Christian Salgado, terrific talk. Rafael Cortez, an outstanding presentation. We have to pay attention to each of one of the conditions in our daily practices. Thank you very much. Tamara, was all the ischemic neuropathies associated with young cell arteritis? What percentage are retrobulbar or posterior? What is the percentage?
So most of the patients have ischemic optic neuropathy, the regular type. That's 80% of the people. So people that have the posterior are the minority. That's maybe 10%. And then CREO, 10%. Most are anterior.
Okay. Andrea Cabrera, she's from Bolivia and in Paraguay now. Say, thank you, doctor. Amazing presentation, excellent. Kelly also, thank you for many tips. Excellent, Dr. Andrew. She say, Francis, congratulations. Our great team from Paraguay. Natalie Briceño, welcome. Thank you for sharing your knowledge. Paula Riaza, she's in Chile. Excellent, thanks. Okay, Yubiris, you want to do a question? You can turn off your microphone. If somebody want to do a question.
How are you, Dr. Lee? Thank you for such a marvelous, marvelous presentation. I just want to understand something. Do you do images in all third nerve palsy?
Yes. So the only one you don't have to scan is a complete palsy. That means the lid is all the way down. All the muscles are involved of 3.
Okay.
And the pupil is completely normal. And they have a reason for having a vascular path. Ideally, they're already getting better. So that person, you don't have to scan. Everybody else, you have to scan them.
Okay. Okay. Thank you. Thank you.
Guillermo Raro, que say, the people that know is no. Pedro Luis Cárdenas, thank you for the excellent talk. They are from Colombia, boss. Asdrubal, do you want to talk, Asdrubal? Do you want to say? Do you want to do?
Okay. Yeah.
Okay.
Hi. Do you hear me?
Yes, perfect. Uh-huh.
Okay. Hi, Dr. Lee. Thank you very much for your wonderful talk. I was wondering, do you think it's possible to diagnose a pituitary tumor before any symptoms or bilateral hemianopsia? Do you think we could have ganglion cell loss before perimetric loss in these patients and probably look at them at a scan made by someone that's suspicious of a nerve?
So when you have visual loss from pituitary adenoma, it has to get out of the cella and it has to hit the chiasm. So just having a tumor won't cause vision loss. The ganglion cell loss definitely occurs, and we can see it as a bitemporal on the ganglion cell layer in patients who have visual field defects. I have not seen it used pre-symptomatically, that is without any visual loss to measure, but I think it does correlate. I think there is good structure function correlate between bitemporal hemianopsias and vision loss and the ganglion cell layer loss. The way I use the ganglion cell in that setting is when the patients have a terrible field or they're unreliable. In that setting, the ganglion cell layer tells us a lot of information and you don't have to rely upon the patient's field anymore. So the unreliable field patient, I think your point is a good one. We can do the retinal ganglion cell layer and have a structural measure, even if their field is not reliable, that could show us a bitemporal on the ganglion cell layer.
Let me kick in here. You can certainly see ganglion cell loss by nasal ganglion cell loss well before you have field loss. You can have binasal ganglion cell loss with bitemporal hemianopia with complete recovery of the visual fields. And so therefore it's very useful, I think, in following these patients. So I'm now getting ganglion cell layer on all pituitaries just to predict and stay ahead of the functional loss by that means.
Yeah, I think that's a great point, especially because the fields, you know how these people's fields are. And also the field, when they don't feel like doing a field after surgery. So I agree with that completely.
Thank you very much, also Dr. Hedges.
Yes. Olga Fraga from Venezuela say, great webinar. Olga Toro from Colombia, thank you, doctor. Daniel Haspe, Dr. Lee, thank you for the excellent class from Neurosurgery Hospital Universitario de Caracas. Rafael Musi say, very nice and practical presentation. Congratulations. Mariana Virgil from Argentina says, thank you very much for this excellent talk and for giving us your experience in an amazing presentation. Aide Martinez, in pituitary apoplexia, which percent resolve this medication and which need surgery in your experience?
So in the pituitary apoplexy patients, the major concerns are their endocrine, which is the emergent things, and then the compressive component. So if it's apoplexy without compression, they actually don't have to go to surgery right away. It's the compression ones that have to go to surgery with the big hemorrhage and the bitemporal. But they're little apoplexies and they're big apoplexies. The little apoplexies you can treat medically just like you would little pituitary adenoma, but it's still apoplexy. Those people, the endocrine is the major problem there. They have to be admitted for that.
Okay.
Okay. Dolly Colorado has a question. Great conference. Dr. Andrew, a friend whose general patrocinator just asked me about this case. 43-year-old man, all female, diabetic, presents in the ER, referred she lost visual acute abruptly. Both pupils are dilated and unresponsive. There is no relative afferent pupillary defect, no ptosis, no exo. Where are you thought on that? Thank you.
So you can have dilated pupils from afferent disease or efferent disease. If it's afferent disease, that the person's no light perception, the pupil won't constrict because it doesn't perceive any light. In that setting, we can tell that that's afferent because we can do the near reaction. So if the pupil doesn't react to light, but it does react to near, then that tells you the efferent pathway is intact. And so a person who is blind from anterior visual pathway disease can have this finding, both pupils dilated and unresponsive, and they can't see. And if the fundus is normal, then that's a retrobulbar optic neuropathy. So that needs the imaging, and you got to think about the usual suspects, NMO, MOG, tumor. That could be apoplexy very easily. However, if the pupil doesn't constrict to near and it's dilated and fixed, then we have to think about the efferent pathway. And the most common cause for the efferent pathway, if it's not a third nerve palsy, is something wrong with the ganglion. So if the ganglion is bad, then that's adhestonic pupil. But if it's fixed and dilated big and no near, the light and the near are impaired, then we'll put the drops in. So you can put in the Pilo 1/10% to prove it's not adhestonic pupil. And then you put 1% in to prove if it's pharmacologically dilated. So if it doesn't constrict to pilocarpine 1%, then it's pharmacologically dilated. But first you got to test the near reaction. So we'd like to know if they're NLP or not. We need the near reaction. And if it's afferent, well, then you need to search for an afferent problem. If it's efferent, then it could be adhestonic pupil acutely, or it's pharmacologically dilated, but usually it's like pharmacologically dilated.
Okay. Dolores Rivero from Argentina says, thank you, Dr. Lee, for the talk. Please, can you explain the actual role of the temporal artery Doppler for the confirmation of giant cell arteritis?
So the temporal artery biopsy is still the gold standard for making the diagnosis for giant cell arteritis, but the temporal artery ultrasound is getting better and better. It's very operator dependent. What we're looking for is the same thing that we saw in the path, which is the transluminal infiltrate, and that makes a halo sign, a halo of hypoechoxylic around the temporal artery. So when they put the ultrasound on there, they can see this halo, which is the same thing that we see on the path specimen as transluminal infiltrate. The sensitivity and specificity of the temporal artery ultrasound is still iffy, and it's very operator dependent. However, I use it if the person can't have a temporal artery ultrasound, or I want to support my clinical decision. So if I think it's giant cell and my surgeons are out of town, or I can't get a temporal artery biopsy, I'll do the ultrasound to help make it easier for me to give the person steroids. We also use it when we don't think it's temporal arteritis. So if I'm trying to convince other people, but I don't want to do a temporal artery biopsy, it's like a 50-year-old patient and their SED rate is 50, and I don't think they have giant cell, we'll use it to prove that it's negative. So I use it when I don't want to do a biopsy or I can't do a biopsy. That's when I use the temporal artery ultrasound. Its sensitivity and specificity are quite variable. If you see the halo sign, I think that's pretty good. Its sensitivity is a little bit iffy. I would never rely upon it alone to rule out giant cell. I would do a temporal artery biopsy in that setting. The other way I use it in patients who have recurrent disease, where they already have a biopsy that was positive and they have more symptoms, we use the ultrasound to look at the other artery. And those cases also support whatever I want to do. So if I want to give more steroids, I'll use the ultrasound to help make my decision. So that's kind of what I do. I think eventually temporal artery ultrasound is going to replace temporal artery biopsy, but not yet.
Okay. Dr. Tamar from Mexico asks,
if you want, I can do the question.
Okay, yes, do it. Come on.
Thank you. Nice to see you, Dr. Lee. I want to ask you about, do you use some drugs such as primornidine or to improve the appearance of a patient with Horner syndrome in the long term, or what treatment do you give them to improve their discomfort regardless of the cause?
So in the Horner syndrome, if you give a direct acting sympathomimetic like brimonidine or aproclonidine, it'll make their lid go up and it'll make their pupil bigger. And so patients like it if they don't want to have surgery. So if they won't want to have surgery, but they want to have something to go take the wedding photograph or they're going on a date, I think it's perfectly fine to let them use the drops for social reasons. And some patients just like it. So I think it's completely appropriate to offer this to people if they like it.
Thank you, Dr. Lee. Nice to see you, Mary.
Okay, in YouTube you have many congratulations, grading from Caracas. Thank you for your time, doctor, from Venezuela. Hello, thank you so much. And also in Facebook you have other congratulations and they say great cases. Let me see. Excellent case. It's a pleasure to see you, Dr. Per Agetoni. And you have another question here from Aide Martinez. Temporal artery Doppler is very useful, but when you begin corticosteroids treatment, how long takes is to to make negative? I follow patient and more or less in 3 weeks it becomes normal.
Yeah, I think that's also a very good observation, and I believe that to be true as well. So as you saw in the path specimen, that when you have the transluminal infiltrate and the luminal narrowing, that's the best one to do the ultrasound on, because that one's going to make the halo sign. But once you give the steroid, the treated or healed arteritis, the transluminal infiltrate is gone, the multinucleated giant cell is gone. All you see is the disruption of the internal elastic lamina and a few focal CD68 positive histiocytes. None of that's going to be seen on an ultrasound. The ultrasound can't see the internal elastic lamina or any of that stuff. So I completely agree that patients who have been treated with steroids for 2 weeks or more are probably going to have a false negative temporal artery ultrasound. So I would not rely upon it after 2 weeks as treatment. It's good in the acute setting right when you begin the steroids. So I agree with that comment.
Also, I read in the new publication is in the European Headache Federation recommendation or another that like this in eye. They say when you begin the treatment with the steroid, it's become the specificity of the Doppler decrease in 60% in the 4th day after treatment.
That's right. And that correlates with the path. So the steroid will totally obliterate the transluminal infiltrate. So you really got to be careful about ultrasound being negative if you have steroid on board.
Okay, let me check if we have another question. Yes, we can see the talk in YouTube. Is Dr. Andrew Lee permit me to keep this?
Yes.
Okay, it's almost, I think we don't have any other questions. You have a lot, congratulations. We can see, let me see, check before close everything in the YouTube and Facebook. I think no more questions. Congratulations, Dr. Luis, thank you.
Yeah.
Okay. Well, thank you so much, Doctor, for help us to teach us today.
Thanks for having me. See you guys later. Bye. Adiós.
Buenas noches, gracias a todos y ya les mando les mandaré lo de la otra semana. Muchísimas gracias.